So I'm pleased to introduce Dr. Torres. Dr. Torres is the leader of the AAN's Healthcare Disparities Work Group, and I will let him do an introduction for Dr. Benson. Thank you.
Thank you, Leah. It is my absolute pleasure to introduce Dr. Richard Benson, who is joining us today. He is a director of the Office of Global Health and Health Disparities at the NINDS Division of Clinical Research. He is a leader in the fields of vascular neurology and health disparities research. His areas of research interest include health disparities, health equity research, minority, community, and global health. Dr. Benson has worked in the public and private sectors and is a volunteer in several professional organizations. He is past president and current board member of the American Heart Association Greater Washington Region. He was a member of the National American Heart Association Stroke Council and is currently an American Academy of Neurology Registries Committee member. Dr. Benson received his BS in chemistry from Fisk University, followed by an MD PhD from Meharry Medical College in neurophysiology, and was elected AOA. Subsequently, he completed his neurology residency at Harvard in Boston and stroke fellowship at Columbia University here in New York City, while obtaining an MS in epidemiology from the Mailman School of Public Health. After fellowship, Dr. Benson worked as a vascular neurologist in New York City at the Long Island Jewish Medical Center and at St. Luke's Roosevelt Medical Center. And in 2005, moved to DC, Washington, DC, to work as program director in the Office of Minority and Health Research at the NINDS. He left the NIH in 2008 to focus on patient care. In 2010, became the Associate Medical Director of the NIH Stroke Program at MedStar Washington Hospital Center and Associate Professor of Clinical Neurology at George Washington University Medical Center, where he stayed until 2019, when he returned to the NIH to direct the Office of Global Health and Health Disparities. So we welcome Dr. Benson today. He has done tremendous work in the field of health disparities and equity research, and we're very eager to for his excellent talk today. Thank you.
Thank you, Dr. Torres, for that extremely warm and kind introduction. It's definitely an honor to be with you all today. I want this to be, it's difficult in the Zoom format in that I can't see faces and we can't sort of interact and ask questions, but I'm going to do the best we can to make this feel like we're having a conversation and sort of discussing things. Our learning objectives for today, the first one is to sort of delineate the need and reasons to have a diverse biomedical research faculty and neurology departments across the United States. I'm going to start by mentioning the mission of the NINDS, which is to seek fundamental knowledge about the brain and nervous system, and to use that knowledge to reduce the burden of neurological disease for all individuals. And the for all is highlighted because it includes the fact that unrepresented populations for a long time have not been included in some of the research enterprise in terms of inclusion in clinical trials, as well as being investigators on some of the studies. And so some of the strategies include investing in basic translational clinical research, identifying gaps, and training the next generation of diverse workforce, and also looking at new discoveries to deal with health disparities in other areas. The NINDS is committed to reducing health disparities, and in fact, it has this statement that it created to mention that fact, that the NINDS is committed to reducing the disproportionate burden of neurological disease borne by underserved groups of society, including racial and ethnic minority, rural, socioeconomically disadvantaged populations, by funding a spectrum of research from basic science through clinical studies and training the next generation of health disparities investigators. Why does diversity matter? We think diversity matters because it allows us to be able to recruit the most talented researchers from all groups. There is no one group. We can use the term race. Race is a social construct, as we know. It's not a biologic construct. but there is no race that has a monopoly on talent or intelligence. So it's important to pick the most talented researchers from all groups. And that's important as well. Having a diversity, it leads to improvement in the quality of educational training. It gives balanced perspectives in setting research priorities, and it creates an improved capacity to recruit subjects from diverse backgrounds into clinical research protocols, and also improves the capacity to address health disparities. The NIH defines diversity as individuals from underrepresented racial and ethnic groups. And I underline here and highlight underrepresented racial and ethnic groups because there are certain groups that are overrepresented in the NIH research enterprise. Individuals with disabilities who are defined as those with physical or mental impairment, and individuals from disadvantaged backgrounds. And this includes socially, culturally, economically, or educationally. And this is applicable through high school and undergraduate candidates. Beyond that, it's a little more difficult to sort of establish the disadvantaged background. We have an office at the NINDS that is focused on enhancing the diversity of the neuroscience workforce. It's called the Open Office, or Office of Programs to Enhance Neuroscience Workforce Diversity. And it's led by one of my colleagues, Dr. Michelle Jones-London. And the goal of this office is to increase the applications from underrepresented groups, enhance outreach, and attract investigators to the neuroscience, diverse investigators, and then support training and capacity. We also focus on, or that office and my office as well, we also focus on identifying bias in peer review, which is a major issue that can impact funding decisions as well. We know this is a nice diagram showing the fact that we have a large population of individuals that are well represented when you think of the typical race, ethnic backgrounds. And from this schematic, we see about 87% of those that submit applications to the NIH actually from some of the overrepresented groups. But we have a very small portion, only about 6% that come from our typically underrepresented groups. And we'd like to increase that number. So the NINDS actually put out a notice of special interest, or NOSI, for our R01 applications that come in from individuals from diverse backgrounds. If someone applies under this NOSI or submits their R01 under this NOSI, that application is actually flagged for high program priority. And we can, through that, when we sort of look at funding decisions, we can look at high program priority candidates and fund those individuals at a different level. So this is another strategy that we're using to try to promote the diversity of underrepresented individuals in the clinical research enterprise. We have some other activities at the NINDS and the NIH that we're doing as well to promote diversity and training. And as I mentioned, this is important in terms of a diversity of ideas, concepts, research topics, and all. So we feel that this is very important. We have the NIH Blueprint to enhance diversity through undergraduate research training. And this has been a very successful program. It's called the Endure program, and it's an R25 program. We have a diversity F31 program, and this is for MD, PhD students from minorities serving as part of the MSTP institutions. We have the DSPAN program, which is a pre-doctoral to postdoctoral program as well. And as well as a diversity K01 program. And I highlight here the NIH faculty institutional recruitment for sustainability transformation program, or FIRST program. This is a unique program actually, and the first cohort was just funded actually and announced this past Monday. And the goal of this program was to create cohorts of diverse candidates who are hired at large academic institutions at the same time so that they can be a support structure for each other. The reason for this is that we found that there's a high rate of attrition or loss of diverse candidates in large academic institutions for various reasons, because of perceived bias or mistreatment or difficulty in getting support for certain research topics. And a lot of people will sort of leave the pipeline. A lot of diverse people will leave the pipeline at that time, and they don't feel as though they have support. And so the goal of this particular program was to fund institutions to hire cohorts of diverse people or people from diverse backgrounds, and they would offer support for each other to try to maintain them in the academic career field. At the bottom of the slide, I just sort of highlight these arrows, just showing that the NIH funds a spectrum of research that goes from actually high school all the way through early career to mid-career stage individuals. There are two other sort of major funding opportunities or initiatives that the NIH has recently started to address this issue of health equity. And one is called the NIH Unite program. If you haven't done it, it would be a good idea to go to the website and sort of look. There's a lot of great information there. But under this Unite program, there were several recent initiatives that were created. Recently, there were two program announcements that were released, and the investigators have been chosen for one of them. The other, we're actually going to there were a couple of applications that were funded under the Transforming Research to Address Health Disparities at Minority Serving Institutions. There were a few that were funded, but we are going to reissue that announcement as well. So if you're interested in that and you're from a minority serving institution, I suggest that you consider looking and reapplying for that. But we received quite a few applications that will be funded under the same initiative, but not specifically at minority serving institutions. And that's the first one listed on this slide. In addition to this, we also are working on a Common Fund initiative. The Common Fund is a fund that supports 10-year grant applications, and it's for high risk, high reward projects. And it's looking for sort of transformation in the research field. And so we're currently, and I'm participating on the committee, I'm the NINDS representative to this Trans NIH initiative. We're developing a plan for a proposal to accept applications that will be transformative in terms of addressing health equity. So this should be coming out at around 2023 as well. So you can look for this as well in the future. The NIH is also committed to ending structural racism. As we all know, this has been highlighted and is now something that a lot of people have focused on because the pandemic actually has forced us to sit in for a period of time, and there were the murder of George Floyd that took place in Minneapolis. That was sort of one thing that sort of ignited people. It was a moment where I think the nation or the world took a collective pause at looking at the amount of racism and cruelty that people have had to deal with in society. And so because of that, a lot of organizations, including the NIH, is focusing on initiatives to try to address this. And we have several things that are listed here on the slide. I won't go through each of these that we've been doing to try to address this. We've had a lot of great listening sessions where even just the NIH employees have been able to voice some concerns and issues that they've dealt with over the years. And so that's been very successful. Here again, I just list a list of the various types of funding mechanisms that the NIH has. And I mentioned that some of them go from high school to faculty, early to mid-career faculty stage. This is sort of our pipeline, as we've talked about, and we think it's important to have a lot of high input at the beginning because there will be attrition along different points of the pipeline. And so that's sort of delineating some of the the needs and the reasons why we feel that and also I feel that a diversified workforce is important, biomedical workforce. Some of the things that that the NIH is doing relative to that field. I'm going to talk next about sort of describing the benefits of having a neurology department that supports a culture of inclusion, equity, and diversity. Going to start out by sort of talking about health disparities. When you think of neurology departments or clinical neurology departments, goes along with clinical care. We have stroke, which is a major area of health disparity and neurological disorders. And it was actually sort of one of the area that sort of got me interested in dealing with health disparities during my neurology residency. And from this diagram, I have on the y-axis age-adjusted stroke mortality, and on the x-axis, I have the number of years from 1999 through 2017. And so we can see that during this period of time from 1999 to 2017, there's been a decrease in age-adjusted stroke mortality for whites. We do see that there is a decrease for Blacks, a decrease for Hispanics, Asian Americans, and Native Americans. However, here on the right side of the screen, I have the mortality ratio using white as a reference. We can see that this mortality ratio for whites compared to Blacks has been quite stable from 1999 to 27, with an excess of 36 to 43% excess mortality for African Americans compared to whites. We did not see a decrease in that over this time period. We actually, last week, we hosted a health disparities workshop at the NINDS, and hopefully some of you on this call in this webinar participated in that. And Dr. George Howard from the University of Alabama participated, and he presented this information that between 1949 and 1951, the white to non-white, and that's led, at that time, it was largely Black that made up the non-white population. Stroke mortality was 1.63 for men and 19.2 for women. And so he actually made a very startling point that in the last 70 years, actually, so that's from 1949 up until now, that we've made little progress to reduce this disparity that we see in stroke in the last 70 years. And that's very startling to think about. And so that's a neurological disorder that shows a direct disparity in a neurological disease. And we have to wonder, why is that there and why is it continued? Historically, people have looked at maybe there's some biologic issue that has led to this disparity. But in 2003, the Institute of Medicine, now known as the National Academies of Science, published a report titled Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare. And this report concluded that racial and ethnic disparities in healthcare exist, and that the sources include the healthcare system, healthcare providers, and patients and utilization managers, and those are all contributors. So what this report, this sort of said that no, it's not some biologic issue that's led to this disparity that we see out in these various diseases, that there's something else that's there. Here I cite, again, some very heartbreaking and startling research that has shown that Black newborns are more likely to die when looked after by white doctors. And the same is not true when white newborns are looked after by Black doctors. And so we have to wonder why this is occurring and why this is an issue. And so this is something that has to be looked at. Here I can show that in this article, it shows that American is failing its Black mothers. When you look at the maternal mortality rate in the United States, and we're a high income developed country, we are not considered the leader when it comes to mortality rates of mothers. We actually have a pretty bad, for considering our income in this country, we have a pretty bad maternal mortality rate for women. when you look at African-American and Hispanic women, the mortality rate is extremely high in this country for us to be a developed country. And so again, this is something that's very startling, and this has been out for a long time. The NIH has targeted funding to look specifically at this maternal mortality rate, and this is something that we're looking at as well. We know that there's been a disparate impact on certain groups, Blacks and whites. I report here in New York. We know the same is true for Native Americans and other groups as well. Due to the COVID-19 pandemic, we've had groups from these underserved communities that have had a very negative or higher burden of death rates associated to the COVID pandemic. This slide is here just to show that there's a disparity in terms of who's getting sick the most. We know initially and early on, it was the first frontline workers who actually had to go and work at grocery stores and work on jobs where they had to show up and they couldn't work from home. And a lot of this was sort of led and directed by level of education. And so we can see that some of the jobs that require more education, then those jobs also tend to have a higher degree of education, and they also tend to be not Black or not Hispanic. They tend to be more Asian or white. So again, this shows that this is another reason why we've had sort of this disparity in the mortality and the morbidity associated with the COVID pandemic. In August of 2020, two of our neurology colleagues or stroke colleagues, Dr. OGHHD Williams and Dr. Bruce Avbiagali, published an article titled "Stroking Out While Black, the Complex Role of Racism." And they actually cited a study from the results of the REGARD study, which is led by Dr. George Howard at the University of Alabama. And he found that only 40% of the Black-white incidence disparities and stroke could be attributed to the prevalence of traditional risk factors. And those are your traditional hypertension, diabetes, and those types of risk factors. And so they postulated or they estimated that 60% of the remaining disparity was related to other unclear factors. And so that's the majority of that sort of difference is related to something else other than traditional risk factors. And so Dr. Williams and Dr. Avbiagali suggested that part of that 60% could be related to racism. And they cited the levels of racism framework, which includes structural racism, which we've talked about, which is a really large area of racism, personalized, internalized racism as well. And so they concluded that in order to address this issue of disparities, particularly in stroke, that we need to use a more equity lens to address that. I highlight here just sort of the three types of racism in the structural racism framework. There's interpersonal racism, and that's sort of the racism that, or internalized racism, sorry. Internalized racism is when someone internalizes certain racist beliefs about oneself, and that leads to the negative outcome. And so I have this diagram in terms of someone, for whatever reason, that may not take proper care of that person's or his or herself, and that leads to negative health implications. And then we have interpersonal racism, and that's when one person does something to someone else directly. We know that that's bad as well. If someone does something to someone else that's racist, it impacts people. If you're in an academic neurology department and the chairman of the department treats the young new faculty member from a diverse background differently, or that person perceives a difference in treatment, that can have negative consequences in terms of that person's ability to practice, to do research, and to stay in that department. And so we know about these, But the sort of the larger one, this structural racism, is one where we're actually putting a lot of thought and research. There's actually a funding announcement that's out recently, and we've received some applications looking at structural racism and how to address this. Structural racism is that structure that's in place that if no one does anything to address it, that it will continue, and those racist practices will continue without any type of alteration. One of those is, we had a great talk from Dr. David Williams from Harvard last week, and he talked about zip codes and the fact that you can look at or determine mortality rates for people based upon the zip code that they live in. Zip codes are very segregated in the United States, and it's based upon housing practices, the way loans are given to people, the way housing projects are set up in certain neighborhoods, the way houses or hospitals are placed in certain neighborhoods, the types of businesses that are in certain neighborhoods. That creates a very segregated microcosm. It's created food deserts and other things where zip codes is sort of an example or a proxy for one's healthcare or health outcome. You can look at a zip code and determine negative or positive outcome for individuals living in that zip code. And so that's one of those structural things that has nothing to do with the person, the child, the person that just happened to grow up or be born in a particular neighborhood, but you're impacted by that. And so those are the other things that we're looking to try to address as well. We do know that there's a lot of things that have persisted in our society here. I just sort of, and the impact of these things continue to affect people in terms of people being treated as property and sold and used as cheap labor. Here, we show women and children working in the field, the impact that this must have had on the mothers, as well as the children, the developing brain in their bodies, the adverse childhood experiences that they were faced because of this. And ultimately this impacted them, and it made it very difficult for them to survive because of that. Here, I use this slide a lot. This is very illustrative, I think, of the point. Some people feel that starting on the left side of the slide, in reality, if you had a metaphor for life of viewing a baseball game, then we could say that there are some people that have really good seats where they can see everything. We can see here in this section on your left. This person actually has really a great perspective and view and can see everything on the field and has all of these boxes that he's standing on top of to see the game. And then we have this person here who's of moderate height, who has one box that he's standing on, but he can still see the game. But then this individual here who has this sort of unique inherent difference, he happens to be shorter than his peers who are sitting here visualizing the game. And in addition to that, he's actually standing in a ditch. So it's impossible for him to see. He doesn't see anything. So some people feel that this is the reality for certain groups here in this country. Equality, the state of equality is sort of giving everyone the same thing. And there were a lot of programs that said, okay, we need to give everybody the same thing and we don't want to give anyone an advantage. And so this sort of comes back to our issue of structural racism, or the point of structural racism that I mentioned, that if you do nothing to change it, that you'll still have these differences. And so here, if you give everyone the same box to stand on, this individual will still be able to see. This person can see, but this person now still can't see the game, even though he's standing on the box. And so the state of equity, which is a state that or an area that a lot of people are looking for us to go to, you give people exactly what they need in order to address those unique challenges or unique inherent differences that individuals have. And so we have here this gentleman who's now standing on the ground. He can still see the game. This individual is standing on the box and can see the game. this individual now has needed 2 boxes, but now is able to see the game. But there's a step further that we can go beyond this. And so we haven't gone and had a lot of discussions about this. You can ask the question, well, why is the fence there in the first place? The fence is obstructing the visual or the view of a lot of people. Why is that fence there? Let's just remove the fence. Do we actually need that fence? Or if a fence is needed, why not a fence that's open so that people can see through it? That's sort of looking at things differently in this and going to that point of liberation. I like this schematic diagram. It makes a lot of different illustrative differences. And so it's important to have people from diverse backgrounds working in neurology departments and clinical care as well. In order to be able to communicate with patients, number one, we need cultural competency. And that's where people sort of understand and appreciate those unique differences in communication and differences in ethnic practices that people may have. And we need to have policies and practices around that, around cultural competency, as well as cultural competency training. This is important in terms of dealing with patients, but it's also important in terms of dealing with colleagues in a particular department. We have to be culturally competent to deal with our colleagues in our neurology departments, with the nurses, the mid-level providers, the techs, the housekeeping staff, everyone. It's important to have cultural competency in order to be able to create an environment where everyone feels that their input is valued. And it is true. We know that everyone's input is valued, including those people that clean the hospital. If we took them out of the hospital, it would be very possible to keep the hospital clean, which would create a big issue for the hospital as well. So everyone has a position and everyone should be respected for the job that they do in that environment. So just to mention a little bit about my journey through this and me, I thank Dr. Torres for the introduction at the beginning, mentioning the various programs, but just my personal journey as an African-American growing up in an inner city here, and I grew up in Akron, Ohio, home of LeBron James, right outside of Cleveland, Ohio. And I, at that time, didn't have anyone in my family that had gone to medical school, so that was new to me. So I knew, however, from an early age, from actually high school, junior high to high school, I knew that I was interested in going into medicine, but didn't have anyone in my family that was that had gone to medical school before. And so in my undergraduate school at Fisk University, I participated in the MARC program, or the Minority Access to Research Careers program. This was a program that actually was funded through the NIH, through my institution. And it allowed me to be able to get exposure to research. I started doing research during my, it's a program, you have to be an academic scholar at that point. I was able to apply, got into the program, did research the summer after my sophomore year of undergraduate school at the University of Cincinnati. I did research during the school year, my junior and senior years. I did research at the NIH one summer and on campus at my home institution. And so that actually gave me the exposure to biomedical research, which was something I had never been exposed to before as well. After that, I applied to medical school, got in and was accepted to different medical schools, but went to Meharry Medical College because I got into the MD PhD program. So in that program, well, let me mention the MARC program, it actually gave a stipend to the students in addition to paying tuition. And the MARC at Meharry Medical College in the MD PhD program, I also paid my tuition and didn't get a stipend in medical school, but it did pay my tuition. So I didn't have to take out a lot of loans to go through medical school. And that also was an NIH funded program that allowed me to take that time, because it's a lot of time, as we all know, to go to medical school, If you're going to get an MD and a PhD, that was 7 years. It's a lot of time. You've already taken out loans. And so that's a reason that a lot of people from underrepresented minority backgrounds don't go into these fields or stay into them for the duration, particularly research fields, because it's expensive to stay in those programs. And it takes a while before you're able to make funds in order to pay back some of the loans. And then I did my stroke fellowship, and I participated in a neuroepidemiology program where I was able to get a master's in epidemiology. That was also NIH funded. And then I had the benefit of participating in 2 programs actually through the AAN, and they were actually responsible for me going into the field of neurology. There was a program called the Hawks Marian Russell Minority Scholars Program. And I think, and I can get clarified or corrected if this is not correct from my AAN colleagues, I believe this was probably one of the first diversity programs to the AAN, and this is back in 1994. And you can see me standing here looking younger and having hair that wasn't hair on my head, and it wasn't white at that time. But Dr. Calhoun, which I think was one of the first neurologists in the United States, I actually worked with him. I attended the American Academy of Neurology annual conference. It was in Washington, D.C. that year, back in 1994. And I went as a student from Meharry Medical College. Dr. Patrick Griffith, who was representing Morehouse College. And then this is Dr. Weir, he was at Howard. And so those are the 3 minority serving or historically Black medical schools in the United States. And this lady is actually, she went into ophthalmology. She was interested in neuro-ophthalmology, but I think I'm not sure she did a neuro-ophthalmology fellowship or not. And I haven't been able to connect with these 2 colleagues to determine what field that they went to, but these are 4 people that the AAN invested in back in 1994. And at least just representing myself, that's basically 25%. Based upon that small investment at that time, they had a great return in terms of investing in me. And here I am making this presentation today to this group and being in a position where I'm able to impact other people, including other people from diverse backgrounds in the field of neurology. After that meeting, I was in my residency in Boston, finishing my neurology residency. And I again attended the American Academy of Neurology annual meeting. It was in Boston that year. And some of these individuals are from the company that had sponsored me initially. And some of them, I believe, worked for the AAN at that time. But this was in 1998. And at this meeting, I actually was able to meet Dr. Rowland, who was the head of the Neurologic Institute at Columbia at the time, and later became an AAN president. And he told me about Ralph Sacco at Columbia and the Northern Manhattan Stroke Study that was looking at differences or the rate of stroke differences in Blacks, whites, and Hispanic living in Northern Manhattan. And that was what got me interested and introduced to that program, and I applied and was able to get into that program. But it was these connections that actually have gotten me to this point. So these diversity programs actually are very important in terms of the next generation. I'm going to quickly talk about sort of what the NINDS and some of our programs and what we're doing to promote diversity and inclusion. I'm going to go through these slides sort of quickly because I presented them last week at our health equity workshop and allow us to have some questions here at the end. But we were recently going through a strategic planning process for health equity at the NINDS. We actually created a working group of our National Advisory Council. We had over 35 experts from across the country. We created a health equity work group, or the HUE, at the NINDS. And we've been meeting, we educate NIH staff about health equity related topics. We do journal clubs, presentations, and we also recently completed a portfolio analysis to look at what the NINDS has funded over the last 5 years. I'm going to talk about that a little more. And we had a request for information that was out there. This information will be presented to our National Advisory Council, and it's also going to be published as well, so that it'll be open for everyone to see. So first, I'm going to talk about our request for information. That's a way that the NIH goes about getting information from the community. We used our regular marketing process that we have at the NIH. We did direct solicitation from various organizations, and we received over 141 responses. And I have here on the right side of the slide where those responders, what the responder types were. We asked questions in terms of, what do you think are areas of health disparities and neurological disorders? We had short answer questions, multiple choice questions, and we asked about vulnerable communities as well. Our respondents were pretty much representative of most of the United States, and we had some international responses as well. Most were from the Northeast. We had fewer from the Southwest. And as you can see from this insert here, the circular diagram, that we didn't receive a whole lot of rural responses, and that is something that we want to work on in the future, because we do know that there are rural disparities as well in neurological diseases. And here I have the distribution of the organizations that responded. We received responses from individuals and organizations. And this slide just shows the various diseases that were represented from the organizations. Most were from either TBI, stroke, or pain. Those were sort of well represented. And we did have some other areas that were less represented as well. And we can see these are the areas of neurological diseases that were considered areas of health disparities. And we can see stroke is at the top and all of the other areas that we list there. And the vulnerable populations that we have on the right, low SES is one of the major responses that we got. And that was actually more than race ethnicity. We do know about the geographic differences, sexual gender minorities, and others that are listed here as well. And we mapped this to a framework that we have here. And there were various types of interventions that were suggested to us. Now I'm going to go into sort of our portfolio analysis as the last part of my talk. We did go back to try to look at what the NINDS has funded over the last 5 years. We didn't do 10 years because it really took a lot. The information that I'm presenting to you, it took us a lot to sort of pull this together. And I thank all of my colleagues at the NINDS for helping me work on this and to pull it together. But we used the NIH research condition and disease categorization data, and we looked at all competing. We only looked at competing grants that were active from January 1st, January 1st through December 31st of FY 2016 to 2020. And then we categorized those projects based on the National Institute of Minority Health and Health Disparities research framework. We started out during that period of time. There were over 9,100 applications that we funded in that 5-year period. We screened those to make sure that they fit our definition of health disparities that we looked at, and that limited that number down to 910. We did more coding and screening at that time and decreased that number to 70. And our final group of what it is that we funded, and these were ones we actually looked through and read through the applications, were 58. So during that 5-year period, we funded 58 grants. And the numbers that I'm about to show to you now are numbers based on our portfolio analysis. And these are not sort of the normally reported numbers that you would see if you went back and looked at this. And so what we can see is that most of our applications that we funded during this period came in they were unsolicited, and we had some that were solicited. And we have sort of the amount of dollars on the right side of your diagram on the y-axis. In 2019, that bump that you see there is due to co-funding multiple applications with NHLBI. Most of the applications were either R01 or U01. However, we did fund some training awards as well, the Ks and the Fs, as we can see here. We felt that we got the most bang for our buck during this period of time with those diversity K awards, because it was a small amount of money, but we had actually a lot of different topics that were funded. And this is also sort of putting in or investing in that next generation of investigators. And we feel that this small investment actually has great return in terms of creating investigators, diverse investigators that are able to sort of do work related to health disparities or health equity. And these are sort of the disease areas that we funded during this time period. Most were in the clinical, the T2 clinical space, very few in the clinical implementation space, and very few sort of in the public health space. And I have some examples listed here in this insert of the types of projects that fell into that T2 clinical research space. In this slide, and this is important as well, that a lot of our work went into observational studies, but our goal now moving forward is to sort of go towards intervention, particularly in areas like stroke, where we know that the risk factors such as hypertension are so important, and we have good interventions to address hypertension. So we want to move from just strictly funding a large number of observational studies and move towards interventional studies as well. And we had, here in this diagram, we can see we had people at our workshop last week that talked about all of these studies that are listed here in the insert. We mapped all of this to the NIMHD framework. I won't go into that right now, but you saw that in the previous work as well. Only 16 applications engaged, had community engagement strategies. And this is something that we'd like to increase moving forward, because it's very important if you're doing clinical research to address health disparities, to engage the community as well. And so that's sort of my last slide. I'm going to stop sharing now and hand it back over to Dr. Torres so that we can address any questions that you may have.
All right, so we're happy to take any questions from anyone that may have them for Dr. Benson. But to start, one of my colleagues from the Diversity Leadership Program actually asked a question. Ryan, it's really nice to hear from you virtually, but she asked, how can we ensure DEI work is more equitably distributed among all faculty, and how can neurology departments in predominantly white areas of the country better attract BIPOC faculty?
Yeah, that's a great question. I think the issue is, so I'll start with the second one first. I think the issue is that people, just as I talked about with the first program, that they created sort of this cohort of individuals from a diverse background who could sort of work together and support each other to stay in the academic field. I think likewise that people feel comfortable living in environments and communities where they're respected. And so I think people, you know, sort of gravitate to these areas where they have other people that they feel comfortable interacting with. So some more rural areas, unfortunately, don't have as many people from diverse backgrounds in those areas. One way to sort of address that is by, you know, increasing the financial compensation in those areas for the individuals to come to certain areas, or sort of going out and sort of soliciting or trying to promote your area to get more diverse people to come there and let them know what you're offering or what types of benefits they can get from working in that community. And I think that would be helpful. In terms of equitably distributing things in various departments, I think it's the job of the leadership at your institution. And so I think it's very difficult if you're from a diverse background and you're the only squeaky wheel at that department. I think it's important for everyone, even if you're not from an underrepresented background, to call out your department leadership and the leaders of your institution if you see that you don't have a diverse department. You need more diversity there, particularly if you're seeing a diverse patient population, that they need to be called out for that. Because oftentimes what happens is that one lone person from the diverse background feels sort of called out to be the only one that's mentioning this. And so it's important for everyone, even if you're not from a background, to be an ally and to speak up and say, hey, we don't have anyone from this particular group represented at our institution, and we see these patients, and so this is important. And so I think that's one way to address it. I think it's the responsibility of the leadership to go out and to seek people to fill in those gaps and to deal with that diversity, because it does truly add to a diversity of ideas and a better end product overall in terms of how your research goes, as well as it attracts more trainees to your institution as well.
We have a question from Mihari, who asks, how do we persuade leadership that diversity and work in disparities is in the best interest of the department and not about being nice?
Yeah, no, that's another. Yeah, so I mean, and that's a great question, and I think some of the points that I mentioned in terms of there have been studies showing that when you take a group of people who are from the same background and that think the same, and you ask them to come up with some innovative idea, and then you take a group of people from diverse backgrounds and put them together, that the group with the people from the diverse background actually come up with projects that have the most innovative ideas as well. So coming up with newer ideas or things that are outside of the box, diversity gives us that diversity of thought as well. It also allows us to be able to relate to people, gives that institution the ability to relate to more people from different diverse backgrounds. If you see a patient population that's very diverse, it's important for those people that are coming to that institution to see people that look like them, particularly if you're interested in enrolling them in clinical studies or clinical trials or any type of research study. It's good to have people who they feel comfortable with. One thing that we found recently is that there was a group recently that was trying to enroll people in a clinical trial, but didn't have anyone in that clinical trial, and it was from a particular demographic, and I'm not going to mention which one, but they didn't have anyone on in that clinical trial, any of the investigators or research assistants that looked like people from that background, and they had a very difficult time enrolling people in a clinical trial. They went and hired someone from that background to be a study coordinator and research assistant, and their enrollment increased dramatically for people from that background. And so there are definitely a lot of benefits to that. But the unfortunate thing is sort of asking that question, and there was a great comment that was made last week at our conference by one of the investigators. And the comment was that we shouldn't have to prove over and over again that people need housing in order to be safe and healthy, or that people need fresh fruit and vegetables to live. We shouldn't have to continue to justify over and over again why it's important to have people from diverse backgrounds participating or being hired at various institutions. But unfortunately, we're at that point.
And Brianna asks, how do you handle backlash that may come with instituting some of these initiatives to promote diversity in academic institutions, especially when they are seen as creating inequity for other historically well-represented groups?
That's a great question. Unfortunately, this is real life, and unfortunately this happens, that there is backlash. I suspect that there will be a backlash to the fact, once we get past this pandemic and we get further away from viewing the murder of George Floyd, and we get further from that, I think that there could potentially be another swing of the pendulum when it comes to a lot of groups dealing with health equity related issues. One way to deal with it is that all of us who are obviously interested in this topic and on this call, that we continue to fight for this, that we educate ourselves through coming to this webinar and the future webinars that will be put on by the AAN in the future, and let people know that this is important. You have to have a tough skin. I hate to say that, but it's true that and I'm sure you know that if you're a person from an underrepresented background that you've made it to this point, then you've had to sort of develop that tough skin. You unfortunately may deal in spaces where you have to deal with those microaggressions. I think it is important for this type of training to occur so that others who are witnessing microaggressions occurring, so that you can speak up, even if it's, I call it sort of that bystander training. So that if you see that there's a microaggression or something negative that's taken place to someone from a diverse background in your department, you should go talk to that person as well, so that that person is not sort of fighting that battle on by him or herself. And so it's a very difficult situation because there is oftentimes backlash in terms of people feeling that, why did you get this special treatment? So I go back to the diagram that I showed of people watching the baseball game. So, you know, you had everybody got one box, but now you were standing in a hole. And so now you have one box and you still can't see. And so unfortunately, others don't see that. They only see it from their perspective. So I think all of us working together, we can change this, but I suspect, and just, you know, history tells us that it's going to be a long time before we see permanent changes.
There's one last question from me. Is there any piece of advice that you would give, personal piece of advice that you would give our early, either early faculty, students, et cetera, who are just starting their careers and want to know, you know, get some advice from someone like yourself who has really changed the field of neurology and diversity for the better?
I would say, and this is something that I learned, and I don't think I mentioned it earlier, I also participated in the diversity leadership training program through the American Academy of Neurology. And actually I did that mid-career. I was faculty at Georgetown and Washington Hospital Center at that time. And it was actually great because it allowed me to sort of look at, I had a lot of lived experience and I still have years to go, but it allowed me to sort of look at a lot of things. And what we talked about, authenticity and leadership. We talked about different leadership styles, and it's important for you as an individual to show up fully as who you are. I think a lot of times as people from diverse, underrepresented backgrounds, we show up as how we think we should look. We show up so that people don't notice us and so that we can fit in. But I think if you do that, that takes away from those unique differences, inherent differences that you have that can be used, like the short guy from the diagram standing in the ditch. He could probably give some really great ideas in terms of how to address issues with the bottom of the fence and the ground and a lot of things, because he's seen it from that perspective. So his perspective would be different. So we bring a lot of things to the table, and you have to bring your whole authentic self to the table. I don't think that I did that early on in life. It was later in life when I started realizing that the health disparities are important, and mentoring people and being able to allow people to be themselves, develop those ideas that are important to them, because if they're important to you, they're probably important to someone else. So my bit of advice would be to bring your authentic self to the table when you're sitting down in your academic neurology meeting with your chairman and others that are sitting there. Your perspective and your background and who you are is important, and you, not just because of your neurology training and your academic skills, but you and your background brings value to that department, and your ideas and your thoughts and how you process things and how you interact with people, that brings value to that department as well. And so it's important to bring that to the table all the time. And so that's one thing that I would say to everyone in closing.
Thank you, Dr. Benson. I think that's all of the questions that we have for today.
And thank you all. It was great. And I look forward to the future webinars on this topic.